So this is a content review of the shock material. Now this is just a down and dirty review of the concepts that you will see as you approach the exam coming up in the not too distant future now. So let me know if you have any questions on anything, and good luck. So as you remember from the PowerPoint, shock is, at the end of the day, poor tissue perfusion. So the different categories of shock are different ways that this occurs. Hypovolemic is basically you've lost fluid, you're hemorrhaging out after a motor vehicle accident, just general fluid loss. And that is the mechanism for hypovolemic shock, leading to poor tissue perfusion. In cardiogenic shock, what you have is a problem with the pump. So yeah, you're not losing blood. Your blood is just fine, but your heart can't pump it around for whatever reason. Whether you've had a big heart attack and now your left ventricle's not working because that tissue died. You have an arrhythmia, like let's say VFib, where the heart isn't beating in a coordinated way, so blood can't get out how it should. Or you have like a cardiomyopathy where the heart just doesn't have the strength to beat. And that would be your heart failure as well. Next, that's listed as distributed. Now, this covers anything where the vessels are the issue. Now, with septic shock, as you'll see, you'll have that endothelial damage that ultimately causes a capillary leak, where you'll have your fluids leak out at that capillary level. We'll talk more about that, as well as neurogenic shock, where you have that discoordination between the sympathetic and the parasympathetic, where you can't constrict your vessels, which we'll also review. And then lastly, anaphylaxis, where you're releasing complement histamine, which all causes dilatation and increased permeability, leading to poor tissue perfusion. Now, that last category, the obstructive, we didn't cover that. We didn't cover this in the PowerPoints, and it's not on the exam, so I'm not even going to introduce that here. But I did want to correct with the cardiogenic shock. When I said cardiomyopathy, the heart just doesn't have the power to beat that. That's not true in all cases of cardiomyopathy. If you remember hypertrophic, it's just that inability to relax. So I wanted to make that correction right away just to avoid any issues in the future. So the first one that we'll start covering is hypovolemic. And let me just quick here change the slide. So the first type of shock was hypovolemic shock. And again, this is where you have massive fluid or blood loss. You get in a big car accident and your leg gets cut off and you're just pouring fluid out your femoral artery. So you can see here the process where you lose a lot of blood. There's not the cardiac output drops because there isn't blood to pump. Now, because of this decreased cardiac output, which will cause the body to release catecholamines, which will increase your heart rate and strength of the contractility, as well as it'll shift interstitial fluid and release aldosterone and ADH to work with the kidneys to conserve more fluid. Now, this increase in volume and increase in heart rate will increase that the blood volume returning to your heart, increasing your cardiac output. Now, this might work momentarily where it does cause that increase, but then you lose more volume and you lose it, which again decreases that cardiac output. It's a downward spiral until eventually your tissues aren't perfused from that lack of volume for whatever reason, nausea, prolonged nausea and vomiting, getting your leg cut off, whatever would decrease fluid in the body. Now, ultimately, this will cause poor tissue perfusion because there's just isn't the volume to get this to your tissues. And that lack of pressure and blood carrying the nutrients to the tissues, ultimately, as we all know, causes them to die. This leads to organ dysfunction and ultimately death if not corrected. The next shock process is cardiogenic shock, and this is just pump failure. Your heart cannot pump, for whatever reason, cannot pump the blood to the pressure it needs to perfuse your tissues. So here is a diagram where you see that the cardiac can't put out as much blood volume or pressure as needed, decreases the cardiac output, decreases your pressure, which starts that downward spiral where the tissues say, hey, I need more pressure here. So your body kicks it into gear. The RAA system is activated, your vessels constrict, which does return more volume to the heart, but the heart is the issue, and the heart can't handle more fluid. And then this increases myocardial demand, making the heart failure worse. So if this is not corrected, obviously you will have difficulty. So now you'll have three issues really. One, the heart cannot put out the blood needed with the amount of pressure to perfuse the tissues distally, but also the blood is backing up to the heart because it can't keep up. And that blood backup increases hydrostatic pressure, forcing fluid or edema into your lungs or into the areas of the body where the blood is coming from. The third issue is that you could have cardiac dysrhythmias. And this first of all, can cause cardiogenic shock on their own, but also exacerbate cardiogenic shock because now the heart is beating in such a way that it's not coordinated or as effective. The most dangerous, of course, is VFib, which is a life-threatening condition because that ventricle is just completely uncoordinated and can't pump out blood almost at all. One very large shock category is distributive, and this encompasses septic, which is a huge area of shock, neurogenic, anaphylaxis. And this is basically an issue with the periphery. Something's going on with the vessels that are making it so the tissues can't be perfused how they should be. Septic shock is probably one of the most common types of shock. And basically what you have is a bacteria, a fungus, a virus entering the bloodstream and causing an overwhelming immune/inflammatory response. Now this could be with the release of endotoxin or exotoxin, depending on the organism, but ultimately this releases pro-inflammatory cytokines, the tumor necrosis factor, the interleukin, pro-inflammatory cytokines. So these pro-inflammatory cytokines activate the complement system, the coagulation system, the kinin system, neutrophils, endothelial, and monocyte macrophage cell activity. And then this releases that anti-inflammatory cytokines, the LPS binding proteins, the IL-1 receptor protagonist, your nitric oxide, which ultimately causes endothelial cell dysfunction. You'll have capillary leak when those vessels, because of the inflammatory response, open up to let white blood cells through, but this happens all over. So those capillaries just leak fluid. You have microvascular thrombus, you have cell adhesion, ultimately leading to tissue hypoxia, apoptosis, impaired vascular tone, and free radical damage. All these things together will cause multi-organ dysfunction, seeing as your tissues and your organs aren't being perfused and will die. Your body shunts the blood away from anything non-essential and puts it to your heart, your brain, your lungs, and liver. So you'll see altered mental status. You'll see a drop off in urine output. You'll see low blood pressure, obviously, and then tachycardia to try to increase it. But ultimately, if not corrected, this will cause death. Now, anaphylaxis is elicited on a second exposure to an antigen where you've already made IgE immunoglobulins. Now, upon that second interaction, you get complement, histamine, kinin, and prostaglandin release, which ultimately increases capillary permeability, peripheral vasodilation, and constriction of smooth muscles like in the bronchus, in your larynx, and GI system. Now, due to this increased capillary permeability and peripheral vasodilatation, you'll have once again those leaky vessels where fluid can leak out, causing edema. You'll have decreased systemic vascular resistance, causing that hypotension, which will ultimately cause decreased cardiac output, decreased tissue perfusion, hence the shock piece. And ultimately, the patient will die if this isn't treated in some way. Now, shifting gears over to neurogenic shock, what you basically have because of damage to the brain or to like a high spinal cord, you'll lose your sympathetic tone. Now, your sympathetic tone is your fight or flight, and that regulates vessel constriction. So, without that vessel constriction, you have the parasympathetic system, which is your rest and digest, causing massive vasodilatation. Now, this massive vasodilatation decreases your systemic vascular resistance. So once again, you don't have the volume circulating through because your vessels have dilated and can't constrict it to put it more centrally. Now, this ultimately leads to decreased tissue perfusion, shock states, and once again, you can go into multi-organ dysfunction and ultimately death if not treated. So now we're going to take a second and see how these different shock syndromes will manifest in the patient. We all know that the exams have patient examples. So the first thing you'll notice is with the heart or the respiratory rate, which will go up in all these syndromes. Now, anaphylaxis is a little tricky because you have that bronchospasm, but your body is trying to blow off CO2 because of the acidosis due to the lactic acid. So you will see your respiratory rate go up. The next category is your heart rate. And in all of this, all the syndromes except for neurogenic, it also goes up because you're trying to increase your blood pressure. And blood pressure is heart rate times cardiac output. It reflects heart rate and cardiac output. So if you don't have your cardiac output, you're going to want to increase your heart rate to maintain your pressure. And then in neurogenic, as we discussed before, you have your parasympathetic system, which will ultimately cause bradycardia. The next category is blood pressure. It's poor tissue perfusion because you don't have the pressure. So your blood pressure is going to go down in all of these. That's a gimme. Now your skin is a little different. Your skin can become cool, clammy, and pale because blood is shunting away from the periphery to get it central to perfuse your most important organs. But you can also have flushed with anaphylaxis because you have that vasodilatation of the blood going into the periphery. Also in septic, if you have a high temp, it'll cause that vasodilatation where you will have that flushed skin. The like hot because you have a fever. Neurogenic, warm and flush because of the parasympathetic. So skin can really go both ways. Urine output, that's just wrong on the septic part. Urine output goes down in septic shock. That's in the book, the PowerPoint, and that's what I see in practice as well. And then that last column really goes through some of the specifics to the different shock categories. Anaphylaxis, you'll see hives, obviously, cardiogenic, chest pain, hypovolemia, confusion, weakness, dizziness. This is all stuff from just having lack of fluid. Again, ignore the obstructive component because we just didn't cover that. And then lastly, neurogenic shock, it talks about paralysis distal to the injury site. And septic is going to be similar to any of your distributive shock, bounding pulse, altered mental status, loss of consciousness. That's because of the lack of perfusion to the brain, which you'll see in many of the other shock categories as well once you get into that multi-organ dysfunction. So that wraps up the content review with these shock syndromes. So as always, if there's any questions or if there is something that isn't quite making sense, please make sure to let me know. I'm more than happy to go through any of this with you, and good luck on the exam.